My name's Catherine and I'm a clinical scientist. Amanda touched on the fact that it's sometimes an uncommon job to come across, and I probably should actually tell you what I do. So before I went into my research post, I was working in the diagnostic field within GI physiology. So that was basically doing tests to try and understand different problems associated with the gut. So that was both upper GI and lower GI. And I think the easiest way to explain it is, for example, if you're referred to for a scan, you go to a radiology department, you might see a radiographer, and they'll take some images. There are other tests that you get in a hospital that don't fall under those categories, and they often might be carried out by clinical scientists. So my work in this project involves looking at the way that the gullet is working in EoE. So I'm going to tell you a little bit about that now. I can make the slides move. There we go. So as an overview of what we're going to talk about, I'm going to tell you what the study's aim is and where it's being carried out. And then there are three major components to the study. So I'm going to tell you about something called high resolution manometry and 24-hour pH impedance testing, and then about the qualitative interviews that we're doing. And then I'm going to give you a little insight into the results to date, which will look at recruitment and also the qualitative work. So the broad aim of this study, which is called SWALLeOeW, is to understand the use and acceptability of physiology testing in eosinophilic esophagitis. Now, I appreciate there's a lot of big words there, so we're going to go into a bit more detail of what that is. So the sites that it's being carried out at are University College Hospital and County Durham and Darlington NHS Foundation Trust. And just recently, in the last week or so, I've had an ethical approval to open up some participant identification sites in York and in North Tees and Hartlepool. So we've slightly extended the study, and they're going to feed into the County Durham and Darlington site. So I know that many of you will be familiar with the process of diagnosing EoE, but perhaps others are not. So I'm going to cover that anyway, just to make sure that we're all on the same page and we're all starting from the same starting point. So EoE is diagnosed generally using an endoscopy, so a camera test where somebody has a look inside the esophagus, and sometimes the esophagus might appear to have narrowing, or it might have rings, or what we call trachealization. Sometimes it can also appear normal. So a tissue sample would be taken, something called a biopsy, and the thing that's being looked for there is the presence of these specific cells called eosinophils, which are white blood cells that are not normally found within the esophagus. And if they are found, and there are also symptoms consistent with EoE present, so that's things like difficulty swallowing, food getting stuck, chest pain, then a diagnosis of EoE can be made. Keep pressing my arrow and it doesn't work. There we go. So there are a number of treatments available for treating EoE. These include going on a food elimination diet, taking proton pump inhibitors, taking topical steroids, and in some cases, physical dilatation is needed if there is evidence of narrowing within the esophagus. And the majority of people who go into treatment do achieve what we call histological remission. So that's getting the number of eosinophils within the esophagus down to a normal level. However, some people do continue to have symptoms. So that leads us to ask the question, is the esophagus actually working properly when somebody is eating and drinking? So one of the ways that we can look at the way the gullet is working is using what we call a barium swallow. So what you can see here on this image is an X-ray, and the person has been given some barium paste to swallow, and it enables you to have a look at the structure and the function of the esophagus when somebody is drinking the barium fluid. And that can be really helpful because it can enable you to see narrowing within the gullet, which you can see here, there's some narrowing. But again, a little bit like the endoscopy, sometimes it can still appear normal, but someone is still having problems. So the best way to look at what is going wrong when a person's eating in terms of the way that the gullet is functioning is to do a test called high resolution manometry. And this is essentially a test that looks at pressure when someone's eating or drinking, and it enables you to assess whether or not the gullet is squeezing in a coordinated way to push food down from the top of the gullet and down into the stomach. So by doing this test, we can assess what's happening when a person is eating, and we can also have a look at what's happening when they're having symptoms. So during eating, if the person is having symptoms, we're getting real-time information as to what might be going on. And the study involves doing this test both pre and post an episode of treatment. So the treatment is not influenced by the study. That's just part of the normal clinical pathway. So it's a decision between the patient and the clinician. But the study kind of slots in around that. If there's a person participating, and they would just have some additional testing before and after, in line with the endoscopies that take place both before and after a period of treatment, to see how the treatment has affected the eosinophil count. So here I've got a bit of a schematic as to what happens in the gullet when you swallow. So I'm just going to play that for a second just to let you see. So when someone swallows, this is coordinated squeezing that pushes food or drink down from the top of the gullet and into the stomach, and that's what we call peristalsis. So what I'm going to show you now is what a swallow wave looks like on this test high resolution manometry. So essentially what we have is a thin tube with pressure sensors all the way down, and that tube is passed through the nose and down the gullet. And when a person swallows, we pick up pressure information all the way down the length of the gullet. And what you're going to see on this pressure map is that the colours that are red represent a higher squeezing contraction, and colours that are lighter, so greeny, blue colours, are less strong contractions. So I'm just going to play the video again and then start this swallow image in a second. So I'll talk you through that now, because I was trying to do it at the same time as the video, but I can appreciate that when you see something for the first time, it can be really strange to interpret. So here at the top, where I'm wiggling my mouse, if you can see that, is the muscle that's at the top of the gullet. And so you can see there's some red here, there's a contraction, so that's a muscle working away. And at the point that the person swallows, it fades away, and that's to enable food or drink to pass into the gullet. And behind the food, there's this contraction wave, and that's what a nice normal swallow would look like when a person is eating or drinking. So we can look at these pressure plots and see, is the esophagus working normally? What's happening when a person's having symptoms? And how does that change pre and post treatment? So the second part of the research study involves doing a 24-hour pH impedance test. So this is another test that involves a fine tube that goes through the nose and down the gullet. This is about a little bit thinner than a piece of spaghetti. And I know that probably sounds not very nice. What I would say is that generally people do tolerate this test quite well. It's something that you'd be aware of within the 24 hours, but it's most people manage to go about their normal daily activities. People can work, you can eat and drink and sleep. So this tube is in place for 24 hours, and it's really looking at a couple of things within the gullet. It measures reflux, so it has a look to see how much acid is coming out of the stomach and into the gullet over a 24-hour period. And it also looks at inflammation within the gullet, so it has particular sensors along the tube that enable us to look at inflammation. And again, we can see then both before and after an episode of treatment, how does that change? How does that inflammation change with the treatment? And the final part of the study involves doing some qualitative interviews. And now I was not familiar with what a qualitative interview was before I started this project. So just to give you a bit of an insight, in case there are other people out there who are not experts, the work that I've just described beforehand we would class as quantitative. And the information that we get from that is in the form of numbers and statistics, and we look and see oh, would that be representative of a population? What conclusions can we draw from that? Qualitative research is quite different. It's getting people to speak about their experiences. So my research involves what we call semi-structured interviews. So I ask some questions and then just let people answer those questions and just speak freely. And what I'm trying to understand is how acceptable these tests are in people with EoE, and also what the long-term views are on living with EoE. Because if we're going to put something into a patient pathway and change it, it needs to be acceptable to patients, but it also has to have value to the care pathway. So in terms of results to date, as I just mentioned, there are two sides to this research, the quantitative and the qualitative side, and it's not possible to conclude anything from the quantitative side at this point because you have to have enough people to look at to be able to draw any patterns or conclusions from the data. But one of the important outcomes at this point is recruitment, because this is what we call a feasibility study. So we need to be able to understand what are the barriers to the research, and that includes things like how acceptable the tests are, what's the dropout, what's the uptake like. So just to give you a little insight into what's happening to date. So I've given out 30 patient information sheets, and of those, we've had 11 people who have consented and participated in the study, and we've currently got 6 people in the pre-screening, which basically means they've said they are going to participate and they're waiting on an appointment. So of the people who've participated, 7 of those have been interviewed, and 2 of those interviews are scheduled actually this week. 6 people have completed the study in full. 1 is currently in the study because there's a pre and post treatment element to it. That spans about 4 months. So there's usually people that are still in the study ticking away. And then we've got 4 patients who have partially completed the study. And that's for various reasons. So for example, one person decided not to take the treatment for their EoE, so the repeat tests were not so relevant at that point. One person only consented to one element of the study, so they wanted to do the manometry side, which is the swallowing part, but not the 24-hour test. One person wasn't able to tolerate the test, and one person felt unable to tolerate doing it again, but managed it in the first place. So that's an insight into where we're at currently, and this type of information will help us to know that how we would scale up the study if we wanted to. So I said that I can't really comment on the quantitative outcomes at this point, but the qualitative part is actually analysed in quite a different way. So we call it iterative analysis. So as we go along, we do interviews with people, but analysing that data to understand what's happening. And sometimes that might even change some of the questions that you ask for future people. And now it's obviously early days in terms of analysing this information, but there are already some ideas that are forming in my head about what might be important from the data in terms of what people say. So one of the things that I've picked out is the concept of diagnostic clarity. And the thing that I'm getting at here is that actually there's more to it's more than just being given a diagnosis of a condition and then kind of moving on with life and that being that. And I've kind of to explain this better, I've broken this down into 3 elements. So into the pre-diagnosis, the diagnosis, and then the post-diagnostic phase. And what I'm going to do is show you some extracts of what people have said and try to explain the idea. So in the beginning, before diagnosis, there are a few kind of schools of thought. So for some people, there's definitely a message that the biggest concern and the biggest worry is that it's something sinister. So this is somebody saying, getting told to be put on a cancer pathway and stuff like that. It was a bit scary. And on the flip side, when I've been interviewing people, I've also heard a lot about things being normalized. So people thinking actually this is just typical behavior and there's not something wrong. So this person said everyone gets that when you eat fast, and this was somebody who took a long time to actually seek help for the condition because his friends around him were saying, oh no, everyone has that problem. So that's the kind of initial phase in the pre-diagnosis. Now, at the point where someone gets a diagnosis, what I found is to be quite interesting and quite stark is that often there's a focus on what it's not. So it's not necessarily that that moment of getting a diagnosis of EoE answers all the questions. Sometimes it's the focus is on, okay, well, it's not cancer. And this is a different patient saying, all I took from the report was it's not cancer. And actually this person didn't even really process that they had a diagnosis of something else. The focus was all on the not cancer. Other people describe shock, and other people describe relief and validation. So this person is saying people made me think I was mental, and they had felt as though they had been being told they had anxiety the whole time, and they experienced a huge amount of relief to actually receive a positive diagnosis. So I'm looking at the concept of, yeah, clarity here. What isn't it and what is it? And then post-diagnosis, something that I've found is that being able to have the language to talk about EoE and to talk about the condition and what it means is really important to people. And even participating in the study and having someone like me, a researcher, for people to sit down and talk to, I think people have found particularly helpful. So someone here is saying, it's given me just the diagnosis. I've been able to reach out and say, I'm really sorry I haven't been in touch, or I didn't go to X event, but this is why. And this person had felt previously as though she was letting people down in her social life, her friends, her family, but she couldn't articulate why that was. And actually it was because she was terrified to go out to eat. But actually having something that she could then go and explain has been really helpful for her. And then finally, expanding on the what it is and what it's not idea. In the post-diagnosis phase, this research study comes in because the person may already have the diagnosis of EoE, but there are so many outstanding questions, and that can be related to a number of things. But the study itself gives, even though this is research, we do these tests in other groups of patients. So the people who've participated do get a standard clinical report, so they get information on what's been seen in their visits. And so that's information on their general motility, so that's how their esophagus is working on a general level, on general inflammation information, and on reflux. So this person here, I'll just read you the quote. So he asked the doctor, what is it for? And he said, it's for acid reflux. And I said, I don't have acid reflux. And he said, well, you will have. We've since, and then this is the patient going on to say, we've since proven that that was wrong. This is an assumption that seems to be made that you have acid reflux because you have EoE, and I think it's fair to say that you've proved that not to be correct. So again, this is this idea that actually that people sometimes also find it as helpful to exclude something as they do to include something. So this person particularly didn't want to be on medication for something that he didn't have, and doing the tests gave him that clarity and validation as to what it was. So this is a sort of emerging idea. As I said, there's lots more to analyse, and I have a patient public involvement group who are going to look at some of this data with me, because it's always good to get different perspectives on these things, and particularly when it's what people are saying. It could be that someone interprets something differently to someone else. So yeah, but that's a little insight into what I've been thinking about. And obviously the study is ongoing. We're going to be recruiting for another year, approximately a year. So this is to be continued. And these are the people I would like to thank. So these are my supervisory team and collaborators. And thank you all for listening.